Thank you very much, Mr. Chairman. I would like to thank Professor Khazam for inviting me to give this lecture. I will talk on another biomarker for risk stratification and in heart failure. Actually, many of these biomarkers were already described and discussed during this 3 days meeting. And so I'll go through most important one, especially those related to risk stratification of heart failure. Actually, biomarkers for heart failure, they are divided into 3 types. Either for diagnosis, and this is in order to help to establish the diagnosis of heart failure, and also some of them, they are to understand the underlying pathophysiology of development of heart failure. The other types of markers, they are for risk stratifications. And this is to determine the level of severity of heart failure and to detect the adverse consequences. Some biomarkers are very important in order to detect, to monitor the therapy and to monitor the response to therapy. So in my topic now, I will concentrate on markers that are very important in risk stratification to see the risk stratification in heart failure. And as you know, heart failure is a multi-system disorder. It involves not only the heart, but involves other systems, including the kidney, lung, nervous system, and especially, actually all systems are involved in this multi-systemic disorder. And the main pathophysiology in heart failure is low tissue perfusion. So all tissues with different frequencies, they are affected by low perfusion. And this, of course, low perfusion will lead to all the consequences and sequelae that we see it in heart failure. All the signs and symptoms that you see it in heart failure, they are mainly related to low tissue perfusion. And all the complications, they are due to low tissue perfusion. Of course, when you have low tissue perfusion, there are physiological first to correct the low perfusion, and then we have pathologic changes in different tissue, and including the heart, where we have the damage to the different cells in the heart, most important for us, of course, the cardiomyocytes. And this, of course, this damage will lead to many changes, which will be in form of proteins that are secreted in the plasma. And these proteins, when they are secreted in the plasma, we detect them and become biomarkers for diagnosing heart failure, some of them, and some of them, they will be for diagnosing the risk, the sequelae, the outcome of heart failure, whether regarding its progression or whether regarding monitoring the therapy and response to therapy. And these categories will include myocyte injury and oxidative stress markers, inflammatory markers, and renal dysfunction markers, and neurohormonal activation, and matrix remodeling, and myocardial stretch. All these changes will happen in heart failure, as I said, in response to tissue hypoxia or poor perfusion of tissue, and will determine the outcome of heart failure depending on expression of these markers. So risk stratification biomarkers, as I show you in this, including inflammation. And in the inflammation, of course, we have many markers, but I choose some important ones, which are very common. Actually, C-reactive acute phase protein with TNF-alpha and interleukin, these are all acute phase protein with FAS, which is a apoptotic pathway, extrinsic pathway of apoptosis. These are very important markers. I will talk briefly of each one of these. And oxidative stress, and we have many of these, but these are oxidized LDL, myeloperoxidase, urinary biopyrines, urinary and plasma isoprostanes, and matrix remodeling, which is very important, of course, markers, galactine-3, and galactine-3, I will share with you a local work, experimental work on animal, which done in my lab in UAE University College of Medicine, and also matrix metalloproteinase, an enzyme, collagen propeptides, which are two propeptides are very important, adiponectin and osteoprotein, and all these are important for remodeling. Also, neurohormonal activation, including noradrenaline, renin, angiotensin 2, aldosterone, arginine, vasopressin, and endothelin 1. Myocyte injury, and the most popular one, of course, we know it, is the troponin I and T, and myosin light chain, and heart type fatty acids, creatinine kinase, MB, and others, of course. We have many of these, but I choose these only now. And myocyte stress, and the most important and popular, these two peptides, the BMP and NT-proBNP. These are two very important peptides used to diagnose heart failure as well as for risk stratification, ST2 and mid-regional fragment of proadrenomedullin. Renal dysfunction, actually, I will go through Engel. It is very important, really, for diagnosing acute kidney injury, and now they found it's very important for risk stratification in acute heart failure, together with BMP. So for inflammatory markers, as you know, C-reactive protein, very well known, acute phase protein, and they found it is very high in heart failure. And they found it also, it is associated with actually, it causes injury to the endothelial cells, and this lead, of course, to reduce the production, a very well and important vasodilator, which is the nitric oxide, and also it increases endothelin 1, which is a very potent vasoconstrictor, which of course will lead to local ischemia, and of course will lead to damage to the cell. So this, of course, will lead to induction of endothelial adhesion molecules and lead to, of course, increase. They found it have associated with bad outcome in heart failure. So many trials were done to find blockers for C-reactive protein in order to minimize the damage that happens to the heart, but still it's in research. Actually, its increase in the serum is not very specific because it can increase in any inflammatory process, and that's why it decreases its importance. We have the tumor necrosis factor, it's acute phase protein. Again, this factor, they found it is associated with increased mortality in heart failure. Interleukin 1, another acute phase protein, they found it to be increased in heart failure, and also it is associated with poor prognosis in heart failure. Again, interleukin 6, this is another one which is also associated with poor outcome when it increases. For all these inflammatory markers, actually, when they are increased in patients with heart failure, it indicates that there is an inflammatory process somewhere happened. So, and this is, of course, as I said in the beginning, is due to poor tissue perfusion. So, poor tissue perfusion will lead to death of cells by apoptosis or by necrosis. And this death of cells by apoptosis or necrosis will elicit or lead to acute inflammatory process. So, these, when they are increased, indicate that there is a damage in the heart in cases of heart failure. This will show you the interleukin 6 function in the cardiomyocytes. And as you see here, increased level of interleukin 6 is associated with remodeling. It increases collagen and increased fibroblast proliferation. So all these, of course, will lead to remodeling of the heart, increased collagen density, increased ventricular concentration or content of collagen fiber, and of course this will affect the function of the myocardium, and of course it deteriorates or worsen the heart failure. As well as it has a trophic function through stimulation of JAK pathway, and this of course will lead to hypertrophy. Again, hypertrophy is part of remodeling, and this will of course add more to the burden of the heart. And again, it acts on MAPK and it leads to apoptosis. Again, it has also action on cytoskeleton, on sarcomeric proteins, and of course it will lead to abnormality in the contraction of the myocardium. In general, these will lead to remodeling and increased fibrosis and affect the function of the heart. So interleukin-6 and TNF-alpha level can be used to predict also future development of heart failure in asymptomatic patients. And blockade of TNF-alpha was of no value actually. It does not reach to benefit to patient with heart failure. FAS legend is an important legend. It initiates actually the extrinsic pathway of apoptosis. So its level in the serum, high level of it, mean it's associated with increased apoptotic, mean loss of cells, and of course initiation of other features and remodeling in the heart. So they found that elevated serum level reported in heart failure and high level associated with severe disease. Blocking of soluble FAS legend in experimental animal reduces post-infarction ventricular remodeling and improves survival. Oxidative stress, also another features and other important markers. Monitoring of these markers can determine the risk of heart failure because these increase oxidative stress, and again, this is also related to inflammation. Because in inflammatory process, we have always increase of oxidative stress. And increase of oxidative stress, of course, it can damage proteins and RNA, intracellular protein and RNA, and of course this might lead to death of the cell by either apoptosis or necrosis, and again the cycle will continue. You have inflammation again, and you have more oxidative stress and damage to the myocardium. And they found it is associated with dysrhythmia and endothelial dysfunction through reduction of NOS activity and inactivation of nitric oxide, and it has worsened the outcome of heart failure. Extracellular matrix remodeling, this is a very important thing, and this is the sequelae really of inflammatory process that we talk about it, and due to inflammation and oxidative stress, you will have, of course, elaboration of many enzymes in the matrix. The most important one is metalloproteinase, and they found because this will digest the collagen and the ground substance material, so increase in the production of this metalloproteinase compared to the inhibitors is associated with poor outcome in heart failure. Abnormal increase in collagen synthesis, actually inflammatory process, loss of cardiomyocytes are end cells. So when they die, actually till now, although now there are some theories about replacement, but it's still not confirmed, but in general, it's an end cell. When they die, they will be replaced by fibrous tissue. So collagen is a marker of death in cell. I mean, because when cardiomyocytes die, it will be replaced by collagen. So increased collagen synthesis mean we have death of cardiomyocytes. I mean, this is, we can correlate it with in such way. So that's why synthesis or increased extracellular matrix breakdown, which is another, give you another idea, which is also correlated with the metalloproteinase, and presence of pro-collagen, pro-peptide of collagen, also increase in the serum, all are correlated with increased fibrosis and poor outcome in heart failure. Neurohormonal, these are, nervous system, sympathetic system will be stimulated secondary to poor perfusion. This is well known in heart failure. And we have many hormones that are secreted due to that. Norepinephrine is one of them, of course, aldosterone, RAS, endothelin, and others, but these are the most important. I will concentrate on them. And of course, this is also associated with the whole inflammatory and oxidative stress. What neurohormones will be, of course, its effect will be not only increasing heart rate and vasoconstriction and other things that we know in order to improve the cardiac output and perfusion, but they also have effect by damaging the cardiomyocytes and some trophic effect also on cells in the interstitium. That's why they are very important for structural remodeling, and they are involvement in, of course, dilatation of the atria and hypertrophy of the cardiomyocyte. This is the trophic effect which I talk about, and fibrosis, and also dedifferentiation and apoptosis and myolysis, which mean damage of the cardiac myocytes. So cardiomyocyte damage not only due to ischemia, cutting off a blood supply, it can be also due to one of these hormones. They can lead all in direct or indirect way. So norepinephrine, everybody knows that's a sympathetic secreted because of the low perfusion in heart failure, so it's secreted by the ganglion cells, and it leads to increase in heart rate, vasoconstriction, and etc. But the most important things for that, it can damage also cardiac myocyte, and also it can lead to fibrosis. It can stimulate fibrosis, and that's why it is very important factor. And they found that increased norepinephrine is associated with, in patients with heart failure, associated with poor outcome. Aldosterone is another hormone, which you know it is secreted from zona glomerulosa of the adrenal gland, and it is important in maintaining sodium level in the blood, and that's why in this event it is stimulated, and there is increase in the secretion of aldosterone in the two, which will lead, of course, to increased sodium level, which will increase the water also with it. But aldosterone is known also to cause fibrosis and cause myocardial or cardiomyocyte damage. And this, of course, will add to the problem of the heart failure and will worsen. That's why increased level of aldosterone is associated with poor outcome in heart failure. Renin-angiotensin system also, it is stimulated due to low perfusion in afferent arteriole of the kidney, and of course to the sodium level in the distal convoluted tubules. All these, of course, stimulate the system, and of course will lead to up regulation, and this, of course, renin-angiotensin system is again associated with remodeling and causing hypertrophy, fibrosis, and rhabdomyolysis, mean loss of cardiomyocytes, and worsen the situation of heart failure. That's why they found that it's increased renin-angiotensin system stimulation of it is associated with poor outcome in heart failure. Endothelin, a most potent vasoconstrictor secreted by endothelial cell, endothelin-1. And of course, it can potentiate the effect of other neurohormones like renin-angiotensin system and aldosterone and others. And that's why it is a very potent cardio remodeling factors, because it can lead to ischemia. It can, of course, lead to damage to the cardiomyocytes, and of course this all lead to increased fibrosis and remodeling. Vasopressin, of course, it has antidiuretic. It is very well known that to be secreted during heart failure, early phase, and of course its secretion will lead to false hyponatremia, delusional hyponatremia, which again it will stimulate the renin-angiotensin system, secondary renin-angiotensinemia, and this of course will lead to the same sequelae which I just mentioned: fibrosis, hypertrophy of cardiomyocyte, and remodeling of the heart, which of course will have poor outcome in heart failure. So the other category will include myocyte injury, other biomarkers, and as I said, cardiomyocyte injury not necessarily due to blockage of the coronary or narrowing of the coronary, mean ischemia, but it can be also due to inflammatory process, oxidative stress, and neurohormonal activation, as I mentioned. All of these together, they can lead also to loss of cardiomyocyte, which will end, of course, with fibrosis. When you have loss of cardiomyocyte, you will have replacement by fibrosis, mean increased fibrosis. This will, of course, affect the function of the ventricles and poor outcome heart failure, or secondary hypertrophy of the survival cardiomyocytes. And again, this will lead to poor outcome in heart failure. What they found actually, there is the best marker for that, of course, you know it is troponin I, and it is very correlated with the amount of necrosis or loss of cardiac myocytes. So that's why they found that increased level of troponin I in patients with heart failure is associated with poor outcome heart failure, and it is very well correlated with mortality, as you see here, in patients with heart failure. Myocyte stress or stretch, myocyte can be stretched or stressed. And of course, this stretching or stress of myocyte will lead to transcription of very important protein, which is brain natriuretic peptides. Brain natriuretic peptides in normal hearts is not present, but its gene is switched off. What we have is the arterial natriuretic peptides, which are present in arterial myocytes, stored there, and they are used when there is stretch or increase in the volume in the atrium. But in the ventricle, BMP is not present. So, what triggers BMP? BMP is triggered when we have volume expansion in the ventricles and pressure overload. And this is a situation where we have it in heart failure. So, this stimulus or this signal will lead to transcription of a pre-hormone BMP. So pre-hormone BMP will be transcribed, and then it will be cleaved inside the cardiomyocyte, ventricular cardiomyocyte, into pro-hormone BMP. The pro-hormone BMP in this situation of where we have volume expansion and pressure overload, mean ventricular dilatation, increased intraventricular pressure, and more residual volume inside the ventricle, of course, will lead to secretion of a prohormone BMP into the circulation. Still, this prohormone BMP is not active. It needs to be activated in the circulation by another cleavage which happens in the circulation by endoprotease. Choline, which will cleave it into two peptides, the active BMP, which we all use it to detect for diagnosis of heart failure, and inactive peptide, which is the N-terminal prohormone BMP. The N-terminal is inactive, but they found it's very important for detection or to measure the outcome of heart failure, which means because it's another way that this hormone or BMP is produced. So we can use both of them as marker to detect the outcome of heart failure. And they found that this marker is very important in diagnosing heart failure, as well as it is very important in follow-up patients with heart failure. And they found that high level of BMP NT-pro BMP, high level associated with poor outcome in patients with heart failure. This is the BMP, and this is the AMP, and as I said, this is already stored in the heart, and the BMP is formed.
You exceeded time, and I will allow you 2 minutes more.
Yes, okay, I will finish quickly. And as I said, it is very important in diagnosis. Renal infection, NGAL, they have it associated with actually, it's very important in diagnosis of acute renal failure, and they found it is very important when combined with BMP in diagnosing acute heart failure and the sequelae of acute heart failure. Galactine-3 is very important. They found it recently to be very important in follow patient with heart failure, and they found it is associated with poor outcome. It's a part of a family of galactines. They are characterized by the presence of carbohydrate recognition domain, which they this is the carbohydrate recognition domain. They attach to galactoside areas in different parts in extracellular matrix and cells, and it is involved in cell proliferation, cell adhesion, and inflammatory process and apoptosis. That's why it is very important in heart failure, and now they use it. So what GALAT3 use? Actually, GALAT3 it binds to quiescent fibroblasts, and this, of course, changed the fibroblasts into myofibroblasts, which are present in the interstitium in the heart. And this, of course, will activate the myofibroblast to secrete collagen fibers. And this, of course, will increase fibrosis. That's why level of galactin-3 is also always linked to the increase in fibrosis. And these are how they discovered it's important in rat model, when they found that its excretion is increased in heart failure, and this is due to fibrosis. And also, when they administered the intrapericardial galactin-3, they found that there is increase in the density of collagen in the ventricle, and this is another proof of its work. And this is how it happens. These are the quiescent cardiomyocytes, and of course leading to increase in fibrosis.
Not realizing. Sorry, please carry on.
Yes, I am just going through that. Actually, it is associated with fibrosis in different model, not only in the heart. And this is in the heart. It shows you that it is increased in fibrosis. And when we knock out the galactin-3, there is no fibrosis in the heart. Actually, this is the work which we have done here, and it shows you the on animal model that we did actually ligation of left anterior descendant artery, and to induce myocardial infarction. And of course, this myocardial infarction, this is the ligation, and this is the pale area following the ligation, in order to study the secretion of galactin-3 in the heart. And actually, this is.
Can you summarize your?
Yeah.
We have to close.
Yeah.
We have to
so this is what we have. So what we found actually, that galactin-3 is secreted very early in the event of ischemia, in the death of the cells, whether due to myocardial infarction, as in this model, or whether due to inflammation. And its secretion actually is increased with the time. So it is not appear during heart failure. I mean, long time after that, but it started very early in the event of ischemia. That's why its monitoring of the level of it is very important for heart failure and for the sequelae of heart failure. And we identify that galactin-3 is not only secreted by cardiac myocytes, but it's also secreted by endothelial cells and many inflammatory cells.
I'm sorry.
Thank you very much. Thank you very much.
Thank you so much.
Thank you very much.
Well, if there's any question, one question we can. Anybody likes to? Yeah, please.
Thanks a lot, Doctor, for the great presentation. Two practical questions.
Yes, tell me.
We are
one question, please. Only one. Sorry, only one question.
Okay. About the negative predictive value of pro-BMB or BMB. We see in the clinical practice again and again, patients presented typical with heart failure, pulmonary edema, EF 20%, and BMB is normal.
Yeah.
What could be the explanation, and which of those great markers is coming to us as next after BMB and troponin? Thank you.
Yeah, of course. Thank you very much for these questions. Yeah, I agree with you. Yes, Sometimes, sometimes not in every BMP. I did it also on animal models. Not every heart failure I found that BMP is actually positive. Some of the cases of BMP, that's why. The reason my last slide, I couldn't give it, but the summary of it is that we should not use only one biomarkers for risk stratification or for diagnosis. We should use multiple markers, biomarkers. As I said here, for example, for chronic heart failure, now I recommend galactine-3. Galactine-3, I recommend it. It is now FDA approved biomarker for heart failure. Galactine-3 is very important. It is missing in the literature. I just published paper on it, and it is missing in the literature actually. On this experimental model which I showed to you. So it is very important, galactine-3. If we combine galactine-3 with BMP, it will be very beneficial. The second thing is that...
maybe I think he can ask this question during lunchtime to you.
Yes.
Thank you so much.
Thank you very much.